Hi, everyone, and welcome to Texas PSR and UT Health Houston Southwest Center for Occupational and Environmental Health's ongoing CME series on climate change and threats to health. I am happy today to introduce two pediatricians to talk to you about child health and how climate change impacts it. I think what we're going to do today is just have y'all go off of mute when we're done with the direct sort of lecture part and ask any questions you have at the end. I don't know, doctors, if you are okay with being interrupted, or should we hold questions till the end?
I'm okay with being interrupted. Yeah,
okay.
Either way, doesn't matter.
Me too. It's a small group, so yeah.
So if y'all have a question during, you can ask it also if it really just seems relevant to that moment. Dr. Sophia Gauthier is a pediatrician who studied medicine at George Washington University School of Medicine and did her residency at St. Christopher's Hospital for Children. She is a pediatric fellow at UT Dell Medical School in Austin right now. And you'll also be hearing from Dr. Folashade Afolabi, who is a pediatric pulmonologist and was educated at UT Southwestern Medical Center and is also an assistant professor in the Department of Pediatrics at UT Southwestern Medical Center in Dallas, Texas. Welcome, y'all. Take it away.
Hello, everyone. Thank you. Okay, thank you, Becky, for the introduction. So Dr. Afolabi and I have no relevant financial relationships to disclose.
Yes. Looks great.
Okay.
Thank you so much. All right, fantastic. You can go next slide. And the next one as well. Perfect. We'll go back to the learning objectives, but essentially Dr. Afolabi and I today will be talking about climate change and health from a pediatrics perspective. And so I'll talk a little bit about heat-related illness, infectious disease, and psychosocial health. And then we'll turn it over to Dr. Afolabi to do her subspecialty and talk about respiratory disease, which truly is the bread and butter of a lot of pediatrics. Talk a little bit about social determinants of health, social risk factors, how they interact with climate impacts on pediatrics. And then we tried to sprinkle in as many initiatives, clinical practice changes, et cetera, things that you could potentially take away to be practical from your practice. Next slide. All right, so many of you I know are already very climate change savvy. But briefly, I'd just like to, this graphic is taken from the AAP, the American Academy of Pediatrics climate change statement that they put out in 2015. And very proud in pediatrics that our professional organization was the first to sort of make a statement about climate change and its relationship to health. So of course, this is two graphs in one overlaid on top of each other. We have carbon dioxide concentration overlaid on global average temperature, which are the colored bars. And this is moving forward in time from the Industrial Revolution until present. And as you know, there's a high linkage between the two of them. And if you click on the next arrow, I should have a little graphic come up, but essentially, and then click on one more arrow, for a long time, we never really exceeded 300 parts per million in terms of CO2 concentration, and now we have exceeded 400. And so the Earth has seen these levels of carbon dioxide production, but the Earth looked very, very different at this period of time. I mean, it was more in early Earth days when it saw these high levels of carbon dioxide concentration, mostly from volcanic eruptions. And so this is, of course, a little bit unprecedented in terms of how our climate is switching. So next slide. Okay, so, and then if you just hit the next arrow, in terms of global disparities, so we know that the top 10% wealthiest countries actually contribute to about 34% of global greenhouse emissions. If you hit the next arrow, we can see that the bottom 50% wealthiest countries contribute to only about 15% of global greenhouse emissions. I think this just highlights the fact that we have a big responsibility here in the US. Next slide. And then additionally, we know that we in the healthcare industry, I think, have a nice opportunity as well to be a part of the solution. So in the US, we contribute to about 9 to 10% of annual carbon emissions. And then globally, on the next button, healthcare industry contributes to about 4% of annual carbon emissions globally. And so this just sort of mirrors the fact that here we are in a resource wealthy country. And so we still contribute greatly to our proportion of our impacts on climate change. Next slide. All right, so now I'll just talk about some healthcare. I'll just kick off with some general healthcare initiatives to combat climate change. So we'll move on to the next slide. These are all things that, small things, you know, that you can start to implement in your practice up to larger things before we get into the meat and potatoes of pediatrics and climate change. So the first thing we'll say is the Choosing Wisely campaign, which we know is a high value care sort of curriculum. You can hit the next arrow. I think this is all about unnecessary costs and waste reduction, you know, instead of ordering lab tests and using equipment, plastics, things like that, that we may not necessarily need. Thinking about what sorts of things in your practice are evidence-based versus not. If this is something more interest to you, of course, establishing a hospital-wide interdisciplinary green team, getting stakeholders from admin, nursing, environmental services, the physician side, et cetera, to come together and see like, hey, is there a project that we can sort of implement? And I'll talk about some successful projects that we've seen at other hospitals. Next, what you can do is the HHS has a health sector climate pledge to decrease greenhouse gas emissions by 50% by 2030 and the net zero emissions by 2050. And so as an institution, you can sign up for this pledge, which would probably also go along with the establishment and green team. Next, this one I think is kind of interesting and sometimes one can say debatable, but we all have retirement accounts through our employer, and those are often managed passively, at least from the employee side, but we do have the ability to go in and change where our investments are, as well as advocate where our investments should be. Of course, stocks are rated on an ESG scale, the environmental, social, and governance rating. And there's debate in terms of how good this scale is, et cetera. But I think there is some value in terms of these are passive ways for us to put our money kind of where our mouth is and sort of grow our investment retirements in terms of companies that are more environmentally friendly. Next, you can join local and national chapters. So on the pediatric side, the AAP has a council on environmental health and climate change. You can just jump in on their listserv and start just seeing what's out there, what emails where people are talking about. And then of course, Texas has the Texas Clinicians for Climate Health as well. So just sort of local groups that you can join. Next, you can always write and submit op-eds to your local newspaper if you're a little bit more advocacy focused. You can call your local representatives as well and talk to them about you know, climate initiatives that you're interested in. And I think one of the biggest things that's really helpful to do, lastly, is to mentor trainees who are interested in climate projects like quality improvement projects and things like that. We have such a wealth of medical students and residents who need to do projects. And I think it's like a great opportunity to help mentor someone in a project and have like an impact in terms of climate health and sustainability, where in a way that is probably more manageable in terms of your workflow. So we'll move on to the next slide. Just want to talk really briefly about green hospital design. Here at UT, we broke ground on a new hot cancer facility. And so I think there's something to be said for having a LEED designation in your hospital. Of course, this is all about building new hospitals and or refurbishing old hospitals. And I think, you know, oftentimes the concern comes from, is this a financial investment that the hospital can make? And there's a lot of good data showing that long-term there's huge savings from the admin side in having a sustainable, eco-friendly design building. So to get a LEED certification, hospitals have to meet certain categories in terms of their waste management and recycling practices, having efficient energy metering, water use reduction. Green spaces, Boston Medical Center is a great example of the beautiful green space in which they harvest a lot of their cafeteria food. And then of course, my like special shout out, since I'm here at Dell Children's with UT Austin, our hospital was built not too long ago, became the world's first LEED Platinum certified hospital. And you can kind of see these like design pieces throughout the hospital. I think it's like a nice inspiration to be a part of that. We'll go to the next slide. In terms of like projects and things like that for your hospital, I wanted to talk about one case study. This comes out of the Ronald Reagan UCLA Medical Center. So they did a needs assessment, showed that about this was about 10 years ago, they showed that about 6,000 disposable gowns were used every day in the hospital, which accounts to over 2 million gowns per year. And they started a pilot study where they tried reusable gowns, found that people thought that they were more comfortable, offered better protection, could be laundered and reused up to 100 times. And over 3 years, the hospital saved over $1 million on purchasing gowns alone. This doesn't even account for the amount of money saved in terms of sending waste for waste management. And they diverted almost 300 tons of waste from landfills by making this switch. Obviously, this is a pretty big scale project, but I think it's important to think about certain practical ideas, especially for people who are really in this headspace about what we can do on the ground. All right, so we'll move on. Those are just a couple nice examples that I thought were pretty inspiring, but I want to move on now specifically to more pediatric health and suggested practice changes for those who are working with children. All right, so we'll move on to the next slide. And so these are all graphs from the National Oceanic and Atmospheric Administration. They essentially just show that heat wave frequency, duration, the length of season and intensity are all increasing since the 1960s. So of course, why does this matter? Next slide. So we know that extreme heat is the greatest cause of environmental mortality. And so this kills more people than hurricanes, lightning, tornadoes, floods, and particularly affects the young and the very young and the very elderly, of course, where we practice is with the very young. And heat becomes the most deadly, essentially when you get into heat-related illnesses, specifically heat stroke, when the core body temperature rises above 40 degrees Celsius, and you can have CNS effects and organ damage, and eventually coma and death. So in pediatrics, heat is actually one of the leading causes of death in US high school athletes. Particularly, we see this in football players and then also some track athletes, mostly because their seasons will start kind of earlier or in the late summer when we see the peak of heat, at least in the United States. And specifically with football players are a little bit more at risk. They tend to have higher BMI. They tend to do practice with more padding on. And so I think that this is a huge opportunity, which I'll talk about in a little bit, for us as physicians and healthcare providers to reach out to our community and teach our coaches and teachers about how to be safe in terms of athletics programs. Young children are also thought to be a bit more physiologically vulnerable to heat stress, given their immature thermoregulatory ability. They actually produce more heat per mass. They have a lower body sweat rate, and they divert a larger portion of their cardiac output towards the periphery when they're in a hot environment. And young children, particularly very young children such as infants, also lack the developmental skills to remove themselves from a hot environment. So your classic example, unfortunately, is a young infant locked in a car. And so this is a very nice opportunity as well to give a lot of anticipatory guidance to our families. And then from a climate change perspective, these longer dry seasons and shorter winter frost seasons leave vegetation dry for longer, which essentially leaves areas a little bit more vulnerable to wildfires. We know that the extent of area burned by wildfires is increasing, with peaks coinciding with the hottest years on record. In a cyclic sort of way, we have substantial greenhouse emissions from wildfires, and so this adds into our increasing carbon emissions as well as climate change. All right, so we'll move to the next slide, where I want to talk a little bit about urban heat islands. So many of you probably are familiar with this concept, but essentially an area usually in an urban location where you have an increase in ambient temperature due to a variety of factors, usually lack of green space, building materials that hold on to heat, heat waste from HVAC systems, etc., wind obstruction from tall buildings. There's been several studies done that have looked at associations between urban heat islands as well as neighborhoods that were historically redlined in the 1930s Many of you know redlining is a colloquial term, but it refers to a discriminatory practice that was put in place in the 1930s, is now illegal, but essentially where certain neighborhoods, usually those with minority populations, were deemed sort of like a worse investment. And so the effects from this, now that we see almost 100 years later, are still remaining in terms of the impacts of having infrastructure that wasn't invested in. And so we do see that urban heat islands, these certain neighborhoods can be up to 7 degrees hotter than surrounding areas. However, it has been documented up to be discrepancies even higher, like 20 degrees higher. I did a lot of my training in North Philadelphia. And if you look at satellite images of the city in North Philadelphia, where the average income is much lower, and a lot of these neighborhoods have suffered from divestment. Most of them are, there's very low green spaces. Most of them are blacktop buildings, and they can get significantly hotter than your wealthier neighborhoods down south, closer to the city center. So we'll go to the next slide. The National Oceanic and Atmospheric Association has been working on a big urban heat island mapping campaign in many cities. And so they have looked at several cities here in Texas, including Houston, Austin, and El Paso. Basically, essentially, they're comparing data on income demographics as well as ambient temperature. And so if you hit the next button, it shows a little bit of data. I just picked El Paso. That shows the average temperature now of 0.3 degrees higher in the lower income neighborhoods compared to neighborhoods with higher income. So we'll go to the next slide. All right, so in terms of like heat and pediatrics, I think a couple of practice changes we can do are screening children for utility and security. Do they have infrastructure in their home? Do they have central AC? Do they have ways to stay cool in their home? I think in families that screen positive for utility and security, can we link families with low-cost energy resources for air conditioning or other sorts of utility needs? You can go to the next one. Documenting is super important. So using ICD-10 code Z77.1, which is essentially code that I'll keep mentioning, but this is a catch-all code for disease related to environmental stresses. And then, of course, the next part is anticipatory guidance on heat safety. So talking to young parents, new parents about infants and locked cars. This is not something that's like in our Bright Futures handout, et cetera. So it can be something that's easily missed to counsel on. And then counseling, reaching out into the community to our schools in terms of athletics programs and teaching coaches how to recognize the signs of heat-related illness and what to do in the field and how to prevent that for our students as well. All right, we'll move on to the next slide. I want to talk a little bit about coastal flooding. And so flooding is, we talked about heat being the most deadly cause of environmental mortality. Well, flooding is the most common natural disaster worldwide. And this is both in industrialized and developed nations alike. And so children in coastal cities are at very large risk of displacement. And so we've been seeing a sustained rise in the number of floods and storms, up to over 300 disasters per year after 2005, which is 14% higher than the previous decade, and more than twice the level that was recorded back in the 80s. And so we know that coastal areas, as we think about Houston, at least here in Texas, but certainly many other places as well, this can cause just general injury when you have the immediate storm surge, drowning, property damage, displacement, home spikes in viral illness, and mold growth. And all of these sorts of, and as well as contribute, especially with displacement and property damage and loss and or injury, can contribute to adverse childhood events, which we know have long-term health effects throughout one's lifetime. In 2023, the EPA put out a report that titled Climate Change in Children's Health and Wellbeing in the U.S. And the report essentially said that if no additional adaptation measures are taken, approximately 185,000 children are reported to lose their homes from coastal flooding if global sea rise exceeds 20 inches. We also know that the impact of flooding is also felt a little bit more acutely in low-income neighborhoods. This was pretty heavily demonstrated in Hurricane Harvey in Houston, where we're seeing something that is we term climate change related gentrification. Essentially, families with means to move to places that are further inland at higher altitude can afford to do so, leaving those at lower income levels at a higher risk of flooding and seeing the consequences of that. And so that is also another sort of disparity that we are seeing, that climate change is coming to light. All right, we'll go to the next slide. So practice changes with respect to flooding. I think screening children for housing insecurity and mental health, especially after any sorts of climate events, severe storms, severe flooding, etc. Documenting, like we mentioned before with that ICD-10 code. And then anticipatory guidance on water safety. So, you know, I think when I lived in Philadelphia, we had a hurricane come through. I've never, in like all this major city, arteries flooded, and there's all these pictures in the news of kids, you know, diving into these flooded highways and streets. But we know that flood water is not very safe to play in because of debris and/or illness. So the dangers of playing or driving in flood water, I think, for our young drivers as well. And we probably all know somebody from when we were a kid who drove into a flooded area. I know probably more than I should. Just because they just weren't educated on the dangers of like at what point a car becomes unsafe in flooded waters. Advocating for childhood swim lessons, you know, keeping our children, giving them the skills to be able to survive throughout instances like this. Linking teenagers with summer lifeguard work opportunities. So this one seems more peripherally involved, but I think one, it advocates for skill sets for our teenagers, it advocates for autonomy, getting a job, something to do over the summers. In Philadelphia, we had a lot of big programs and push to link kids who are looking for summer jobs into lifeguard work opportunities as well. So our teenagers can also come and teach our younger kids, and they can be voices for us. And then lastly, emergency department disaster planning. And so we've seen, you know, Houston has been a success story in terms of the levees they've built and the security that they've built in their hospitals in anticipation of flooding, as well as how they've stocked their different teams. So their emergency department and their disaster response teams, if there's a case where people are trapped in the hospital and shifts can't change out. So I think disaster planning, this is something probably a little bit more important for somebody on the inpatient or the emergency side than the outpatient side, but making sure resources are accessible, health resources for our kids when they need it. All right, we'll go to the next slide. So we'll shift gears to talk about infectious disease, specifically vector-borne disease. And so, of course, I just want to touch base on Lyme disease. We know that Lyme disease is not endemic in Texas, but it is the most common vector-borne disease in the US. So I felt that I couldn't ignore this one. So these maps are from the EPA. And they show the geographic spread of Lyme disease from 1996 to 2018, as you can see, spreading geographically north as well as west into areas that previously was not endemic and the climate was not suitable for their vector. And then the graph on the bottom just shows the increasing incidence of Lyme disease over a 30-year period as well. So we'll go to the next slide. And why is Lyme disease of particular interest to pediatrics? Well, for one reason or another, we know that boys aged 5 through 9 are greatest risk of Lyme disease, whether this is Boy Scout activity or other things going on, playing outside, etc. And so we know that it is postulated that the spread of Lyme disease is likely driven by climate change related extensions into the warm season, which proliferates the proliferation of the black-legged tick. And then I just wanted to make one little comment on a local issue. So we don't have the black-legged tick down here in Texas, but we do have the Lone Star tick. And the Lone Star tick is interestingly associated with something called alpha-gal syndrome, which is a meat protein allergy that can be anaphylactic in nature. And so there is an association with a history of Lone Star tick bites as well as the alpha-gal syndrome. You know, as climate change continues and our warmer seasons get longer, we are seeing an increased spread in the geographic spread of these vectors. So we'll go to the next slide. Similar sort of pattern is being seen with dengue, which is transmitted via the Aedes mosquito. So up to 400 million people globally are infected with dengue virus, and is estimated to be responsible for about 40,000 deaths per year worldwide. And so between 2003 and 2012, there were 154 reported cases of dengue in Texas, and most of these were imported cases. But we do know that the Aedes mosquito population extends well into Texas area. And so if we click a little bit forward, we'll see a map come up. And this map essentially models where we predict where the Aedes mosquito is living currently and where we predict it's going to spread as you get to the warmer colors as the global climate changes. And so essentially just bringing that disease to a greater geographic spread. And this modeling is done over the next century. All right, so we'll go on to the next slide. Practice changes with respect to vector-borne disease. Of course, document, document, document. And then anticipatory guidance in terms of, with kids, giving them safe clothing, teaching parents how to check for ticks, as well as how to prevent tick and mosquito bites. And then the safe use of repellent. A lot of parents are very hesitant to use DEET because of various conceptions that they have. But DEET has been studied and shown to be safe to children as young as 2 months of age. I've had a lot of parents also ask me about alternatives. Picardin's a good alternative. Oil of lemon eucalyptus is actually also pretty efficacious. It just doesn't last as long. And I think, and important to note that Picardin and oil of lemon eucalyptus have not been studied in as young as 2 months of age. And so checking those cutoff dates to see like when it would be age appropriate to use various repellents. And then counseling families that concentration determines the duration of action of that repellent before one has to reapply it, and not its actual effectiveness. And so 50% DEET is just, like a 20% DEET is just as effective as 50% DEET. It just depends on how long you're gonna be outside and whether or not you want to reapply. And of course, long sleeves and things like that for kids. All right, we'll move on to our next slide. So this will move into psychosocial health. So it should come as no surprise that we see spikes in PTSD, depression, and anxiety following climate disasters. Of course, displacement, as we talked about earlier, as a result of natural disasters is an adverse childhood event and is known to have long-lasting mental health impacts throughout somebody's life as well, not just mental health impacts, but also physical health impacts. A lot of this data that I'm about to mention exists in the adult literature, but there is a correlation to suggest that increases in ambient temperature are linked with increases in externalizing behavior such as aggression. There's also an association between heat waves as well as an increase in ED visits for mental health conditions, national suicide rates, as well as deaths due to unintentional and intentional injuries. This is both in the adult world as well as in the adolescent group, age 15 to 18. Additionally, anticholinergic, antipsychotic medications such as olanzapine or quetiapine can interfere with thermoregulation by inhibiting sweating. And both of these drugs, as well as many other antipsychotics such as haloperidol or aripiprazole, also have antidopaminergic activity, and that can increase the body's temperature set point. So I think there's also an opportunity for us to counsel our patients who are taking these medications. Some medications can also increase the risk of dehydration by reducing our thirst drive. Many SSRIs, clonidine, carbamazepine, valproic acid have been found to have this link. And then lastly, I really liked this term, solastalgia. A group of researchers actually surveyed 10,000 young people across 10 different nations. And they found that more than 59% of participants globally were very or extremely worried about the impacts of climate change, and 84% were at least moderately worried. Solastalgia is a term that refers to homesickness when your home is changing. And so it's often applied in the climate world as, the world you live in and what you expect and foresee in the future is changing out of your control. And so we are seeing in the pediatric population, I think the generation below us is a bit more climate savvy in many ways, is developing a lot of actually anxiety and concern over this issue. And that is manifesting itself in terms of mental health. we'll go to the next slide for practice changes. So screening children for mental health, especially after climate events, and getting them linked up with counseling resources, etc. Document, and then giving anticipatory guidance on medication safety. So knowing the antipsychotic side effects and their potential for increasing extreme heat susceptibility, and educating our patients on this as well. All right, so next we're going to move on to the impacts of climate change on pediatric respiratory health, which is Dr. Afolabi's bread and butter. So I'm going to turn it over to her.
I don't know about bread and butter, but I know a little bit. And excuse me if you hear my dog. And so wildfires in children, we know that wildfire smoke, and I'm not going to say this in order, so I apologize, but we know that wildfire smoke, particulate matter, is more toxic than pollution from other sources. And it can it can spread very far. The events can last for weeks to months. So the impact of wildfire smoke can be long lasting. And then with children, they are spending more time outdoors, and they breathe a lot faster, and they take in more air relative to their body weight. And you can see that when you look at a newborn infant, and you can see them, kind of tachypnic with their little, elastically recoily lungs. And then their lungs are developing, right? And so we don't really know what the long-term effects of any type of pollution to this developing lung is, though we are getting some data that shows that it's not good, it's not helpful. And those nasal passages actually don't filter air pollution nearly as well as adult nasal passages, and when they're not snotty. And so they're really very susceptible to the particulate matter and wildfire smoke. Next slide, please. We also know that in utero exposure is associated with preterm birth and just decreased birth weight. So that preterm birth and decreased birth weight also has some implications for alveolar development. And so those children who are smaller and born earlier can have less alveolar development, and then those immature lungs can be exposed to wildfire smoke. And then we see that younger children have more emergency department and healthcare visits for respiratory illnesses during wildfire smoke events than older children. I put younger children again. Younger children have more issues than older children with regard to seeking care. Next slide. And so what are some recommendations? So one thing that I'll kind of bring into this kind of repeatedly is the air quality index, or the different air quality indices that we can use. And then there's some question of the utility of having low cost air sensors, like those purple air monitors, having those in your home or outside of your home. Limiting outdoor activities on poor air quality days. Masking has been proven to be very, very helpful, but we've seen that kids can keep on their masks. It's actually been proven that kids can keep on their masks. I think it's challenging to keep on your mask outside during recess during those hotter days, but they can. And then one thing that I wish I did more with is school-based ventilation advocacy and strategies, because ventilation matters. And in addition to that, those ventilation strategies that are school-based, where kids spend the vast majority of their time during the day, we can maybe translate some of that into some home ventilation strategies as well, some low-cost home strategies. Next slide. And then we'll talk a little bit about ground level ozone. So short-term exposure can cause increased risk of emergency department visits, hospital admissions, asthma exacerbations, and respiratory infections. There's this cool little summer camp study that showed a reduction in lung function with short-term exposure. So kids at summer camp, I believe it was an urban summer camp, did lung function, and they looked at their exposures to ground level ozone, and they had short-term reductions in their lung function. So their forced expiratory volume per second, was shown to be decreased. And then, of course, we see that ozone level, ground level ozone levels less than 50 essentially parts per billion are harmful to human health. And the current EPA standard is 70 parts per billion, which is better than what it was before, but still that EPA standard we need to advocate for and work on. Next slide. So what's something we can do? We can actually educate our families on ozone and your patient's health. And so this is specifically from the EPA. And so this QR code will take you to this slide if you want to scan it. I haven't gone through it. It seems like it's a little bit long. Excuse me. I'm so sorry. But I do plan on going through it eventually, and I'll let you know how it goes. Next slide. Okay, this is really kind of neat but terrible. Thunderstorm asthma. So it happens around the world, but it's mostly described in the US, the UK, Canada, and Australia. And what it is this hyper, I'm so sorry. I didn't take my inhaler today. So the rapid increase in humidity causes this rupturing of grass grain pollens, and those grass grain pollens release all of their badness, and then this can cause significant issues with breathing and asthma exacerbations. Increasing strong rainfalls, increasing atmospheric CO2 concentrations affect plants and pollen. And so pollen emissions are expected to increase by 16 to 40%, depending on what you look at in 20-year modeling. And then shifts in geographic locations to allergenic plant species have been significantly noted. And so what happens though with the thunderstorm asthma is you have this high level of exposure to aeroallergens. Then you have these thunderstorms and wind gusts, usually greater than 40 miles per hour. And then those with allergic rhinitis and grass pollen that are sensitized really have a significant issue. And so there have been studies that have seen increased numbers of ER visits for asthma exacerbations following these significant thunderstorms. They tend to happen in more arid conditions, but they can happen anywhere. Next slide. And so we can look at allergies, viruses, and climate change. Air pollution is a T2 helper T2 helper promoting. So that's along the allergic pathway, and in early life exposures increase the sensitization to aeroallergens and food allergens. And then particulate matter may be a carrier for viral particles. And so so climate change can promote eczema and worsen asthma in human and experimental models by exacerbating this TH helper 2 pathway, this allergic pathway. There's an increased risk of influenza on days with increased PM 2.5 in some studies in China. And then this image that you can see on your right is a proposed mechanism by which air pollutants contribute to viral respiratory infection susceptibility and severity. And you can see that it's really multi-systemic. And so you can look at diesel exhaust particles, and you can see that it has a reduction in natural killer cell cytotoxicity, reduction in interferon production, which is interferon's protective. An increase in PM10 can have an increase in inflammatory cytokines such as IL-6 and IL-8, but a decrease in those protective cytokines, and a decrease in alveolar macrophages, which are the immune cells of your lungs that protect your lungs. I can skip some of this. Nitric oxide, dioxide decreases viral clearance by macrophages. It can impair your epithelial barrier function by making your epithelial barrier more leaky, and it can decrease your mucociliary clearance, which decreases your ability to get all of that, all of those toxins up and out and cough them out. And then there's the cell surface receptor expression and viral entry. I have to tell you, it's so complicated to me, but essentially increased host cells and increased host cell expression can lead to increased viral attachment and viral replication. And then angiotensin 2 expression in the lungs is increased, which can also lead to decreased host cell response. And so it's very multifactorial. This is a really great image from the Journal of Asthma and Allergy. But as we can see, viruses and climate change are a big deal. And I don't think a lot of people really think about that. But there are definitely studies that show that on high pollution days, more children come in with respiratory viruses, upper respiratory viruses, those smaller children over those older children. So this makes a difference. Next slide. And then we can look at illness and climate change as well. So increased temperature variability is linked to increased frequency of healthcare visits for acute bronchitis and pneumonia in children. And they said bronchitis, and I went back and tried to see if they said bronchiolitis, because children don't get bronchitis that frequently, but they didn't. And so when they talk about the increased temperature variability, they're talking not only by temperature variability from day to day, but they're also talking about temperature variability over the course of the day. So we're having more big swings of temperature over the course of the day and we're having more swings of temperature from day to day. And the spring always has this, but it's been more pronounced. Extreme rainfall and flooding is linked to increased daily pediatric hospitalizations, and that might be in part to thunderstorm asthma. And then PM 2.5, PM 10, all of these are linked to increased respiratory virus emergency department visits and pneumonias in children as well. Next slide. Okay, so air quality index and pollution. This is where my meat and potatoes is, air quality index and asthma action plans. So the air quality index and so knowing pollution is a known asthma trigger, right? We know that triggers asthma. There's no question about that. But and we know that there are these air quality index and air quality measurements that are easily accessible to your phone on your phone. But few parents use the air quality index apps to modify their children's outdoor behavior. So less than half of healthcare providers discuss the AQI or air pollution as a trigger at all. And if those who discuss it, few provide guidance for behavior modification. And so everyone with asthma should have an asthma action plan per national and international asthma guidelines. But what we really need are, how do we link these air quality indexes to asthma action plans? I think that's where the studies are ongoing, and I think that would be very helpful. I know at the bedside or in the clinic, in my initial visits, I typically ask, do you know where the weather app is on your phone, and do you know how to use it? And they look at me like I'm crazy, and I'm like, well, do you look at the air quality to see if your child can go out and play, especially in the summer? And they or look at the trends in air quality if you take your baby out more in the mornings and in the evenings when it's cooler. And parents typically know about the index, but they don't use it. And so we spend a lot of time talking about that, because one of the best things you can do for asthma health or for lung health in general is to be active. And so I really don't want to prevent children from being active. So I really want them to come up with those plans on the times where their children can go outside and play. Next slide. So on my left is an asthma care plan or an asthma action plan, and on the right is an air quality index. And I just show you this. I think everybody's seen an air quality index, and they look at the and they show you where and they have a green, orange, red kind of color scheme, and our, asthma action plans have this green, yellow, red color scheme. So this is something that I think can be very easily integrated and not confusing for a patient. And so I really think more studies need to be done for this, but I definitely think this is something that we need to show our patients on a regular basis about, are you looking at the air quality index, and does that guide your care or guide your activities for the day? Next slide. Okay, inhalers. So there's a lot of so we're going through it again. So in 2005, the chlorofluorocarbons, CFCs, were transitioned out into HFAs, hydrofluoroalkylane. And so when I talk to patients and I say, are you using your inhaler? Sometimes I say, are you using your HFA? And that's what it stands for. And that was because the chlorofluorocarbons contributed significantly to greenhouse gases. These were used most frequently in refrigerant and mostly refrigerant and other industrial uses. And the use in inhalers was very, very small, but they still, the law to phase them out still included inhalers. And so the inhalers and all of the refrigerants and other things like that transition to HFAs. Now, there was an issue with the transition to HFAs because people said, yes, it's better than CFCs, but it still contributes to greenhouse gases, and it's still something we're going to have to phase out eventually. And industry, because it was, I believe, because it was a less expensive transition, really gave a lot of pushback for this transition, and now we're going back to trying to phase out HFAs at this point. And so MDI stands for meter dose inhaler, and they account for 13% of the National Health Service's carbon footprint. So inhalers for the National Health Service in the UK account for a big footprint, which I didn't even think of. But one of the issues is that it can be overuse of your reliever medicines or your bronchodilators alone and not your controller. So with asthma, typically you have something that controls your asthma and something that relieves your asthma symptoms. And so your controller is the medicine that you take once or twice a day, every single day, to tamp down the inflammation in your airways. And then you take your bronchodilator when you're having an emergency to open up those airways and relax those airways and prevent bronchoconstriction. And so you have two different inhalers. Oftentimes people don't use their controller, just like they don't take their high blood pressure medicine, because they don't feel the effects of it. And so they'll use their reliever because they clearly feel the effects of the reliever. So they'll use the reliever when they need it. And so we've, and the data has shown that the use of inhaled corticosteroids is safe and effective. And so we really want people to use their controller medicine that is an inhaled corticosteroid. So what are we doing now? We're transitioning to maintenance and reliever therapy per the NHLBI guidelines in the Global Initiative for Asthma Guidelines. And what this maintenance and reliever therapy is, you have one inhaler to use as your maintenance inhaler and your reliever inhaler, because it's a combined medicine with an inhaled corticosteroid, which is what we really want folks to have to help control their asthma, but it also has that bronchodilator. It has a fast-acting, long-acting bronchodilator. So you can't use it with every single inhaler. There are some specific inhalers that you have to use it, that you use it with, but you're using one inhaler. So you're less likely to overuse that inhaler because you're getting the controller medicine that you need. So you're having less you're using fewer inhalers in the first place, right? And in addition to that, it's simplified therapy. So that's the only inhaler that you need. You're not going all over the place looking for an inhaler. And it's been proven to it's been proven to improve asthma control without a shadow of a doubt. And so maintenance and reliever therapy can reduce greenhouse gas emissions. How about that? And then by reducing the use of reliever only. And then dry powdered inhalers. So dry powder and an HFA or an HFA is an inhaler where you always need a spacer. You always need a spacer, right? You don't always need a mask, but you always need a spacer. And you depress it, and it's a fine mist that comes out, and then you synchronize your inhalation. Dry powdered inhalers is where you generate a single powerful inhalation, so that you get this dry powder to your lungs. And they can be difficult to use in children that are less than 6 years of age or with neurodevelopmental delays. We're actually in the middle of a bit of a shortage, or a lot of a shortage, of our HFAs, just because of insurance reasons and pharmaceutical reasons. They're making some transitions, and what is more readily available are the dry powder inhalers. And we're really struggling with these dry powdered inhalers because our patient populations are unable to use them. Are the dry powdered inhalers better for the environment? Yes, without a shadow of a doubt, they're better for the environment. So what should we do? We should probably come up with better and new technology that is actually useful, or can be used by children and those with neurodevelopmental delays. Can we come up with the science to make that happen? I don't think there's much appetite to come up with the science to make that happen, because it's for what they consider a small population, though it's the population that's most heavily affected by viral respiratory illnesses. We can see that they're more prone to wildfire smoke, that they're more prone to the effects of pollutants, and their little lungs are developing. So it would be great if we could come up with better technology, but it would be crucial. But there's not a big appetite for that right now. Next slide. I'm almost over time. I'm so sorry. So we talked a little bit about the single maintenance and reliever therapy. I love it. It's great. Email me, ask me about it. It's actually amazing. It's what I use, but I left my inhaler in my purse in my car right now because I really want to cough. Next slide. Okay, and this just looks at the GINA guidelines that really tell you a little bit more about when you use the for those 12 and above, when you use the SMART therapy. And as you can see in those, the preferred track in those with mild asthma, or steps 1 to 2 for their asthma, they can actually use their inhaler as needed at a low dose. So they don't have to use it every single day as a maintenance. They use it only as needed. And then when they have more severe asthma, they can use it as a maintenance and as a reliever. And then when they're at step 5, they need to see a pulmonologist or allergist. Next slide. And then this is the asthma action plan. Once again, it's green, orange, yellow, and red. So once again, these are asthma action plans that we can utilize for SMART therapy. But it's important, whatever kind of therapy that you use, that you always have an asthma action plan. And once again, we can somehow, we're going to come up with a method to integrate these asthma action plans with air quality indexes. And next slide. Okay, so summary, I said Z codes in the ICD-10 codes, but I meant use your 771 code. Educate your families and patients on air quality in the clinic and at the bedside. Use your resources for AQI and asthma action plans. And then, of course, be an advocate at the bedside, at the hospital and institutional level, and at the city, state, and national level. Advocate, advocate, advocate. Next slide. And those are my references. Any questions?
Thanks y'all so much. We just have a couple minutes. I was going to ask the first question, but I don't want to cut anybody off since we only have 2 minutes. So if anybody has a question, I'm encouraging you to speak up. Nobody is going off silent. So I had a question for Dr. Folashade, because I have a kid with asthma, and I didn't know about the asthma action plan anyway, which I'm mortified anyway. So I mean, I was curious as you were talking about AQI and asthma action plans, you know, what you know about asthma outreach programs for kids who have uncontrolled asthma, because it's something that as an organization we'd like to get into. And Austin had one, but then it shut down. And like we talked about before we opened up today, a lot of good ideas don't get off the ground in Austin. And I'm wondering if there's any best practices in terms of encouraging them in places that don't have them, and what a model program looks like.
Yeah, so your health department doesn't have one? Doesn't have? Oh, wow.
And they're ignoring our emails. We're trying to talk to them about it, and we've been talking to them for 4 months, and I can feel them trying to stop this, right? They're just not responding to emails after 6 weeks. They want us to go away. So
wow. So one of the most helpful things that you can do is know about your asthma action plan, because really asthma self-management is so very important. And I think people really assume that it's common sense, and so they don't do a lot of teaching about it. But you know, the health workers who go out to the homes and they do home inspections and they do education, you know, for the patient can be really, really helpful. And then they can be encouraged to integrate the air quality index education as well. And so there's not any formal education right now that links it. But I know some folks in Pittsburgh, I believe, are working, and maybe in San Diego, are working on some research to help support the integration of air quality index in asthma education. There you go. Yeah.
Sorry. So the outreach worker I spoke to runs the program in San Antonio, which is called
SA Kids Breathe.
SA Kids Breathe. I was like, it's San Antonio Kids Breathe, but that's too long. Anyway, and he was telling me that their biggest issue is often just kids and parents not knowing how to use inhalers properly, and that they just hand out the extenders and show people over and over again how to use their inhalers. And I found that shocking, because that seems so solvable.
It is, and you know, but there are, and spacers are so important, or chambers are so important, but it can be challenging to know how to use, and the education can be challenging, but once you get it, it's super easy. It's a matter of whether they're young enough to understand and use a mask versus whether they don't use one. But that's a lot. Even things like priming your inhaler. Did you know that you can't just take it out of the package and squirt it? And then each different inhaler primes differently. Like the Symbicort is 4 puffs. before it's priming with 4 puffs, and the albuterol, the Ventolin is priming with 2 puffs, but there's another albuterol that you prime with 4 puffs. And so like even things like that can be so very challenging. I think they can make the technology so much easier and so much more straightforward. So this isn't as much of an issue.
Thank you.
Any other questions? We're a little over time. That was fun.
Thank you both so much. Is there a way folks can contact you if they have questions that they're not getting to share right now or that come up in their minds later?
Absolutely. I can put my email in the chat. And thank you everyone for coming by. This was fun.
Great. Thank you both. Have a good night.